Now we're going to be talking about atrial flutter. So atrial flutter usually arises in the right atrium. It's a macro reentrant atrial tachycardia, and it's usually initiated by a PAC, which is a premature atrial complex. We will talk about premature atrial complexes in a follow-up video. So the atrial flutter is classified into two main types. One of these is a typical atrial flutter and atypical atrial flutter. If we look at the structure of the right atrium, you've got our typical atrial flutter, which is, it's based on the direction of the reentrant wave that happens inside the right atrium. So two subtypes of a typical atrial flutter are a clockwise atrial flutter and B, anticlockwise or a counterclockwise atrial flutter. Now, an anticlockwise or a counterclockwise atrial flutter is going to be much more common, and we're going to try to draw it on this image given over here. So usually what tends to happen is that the electricity goes upward or superiorly on the interatrial septum and across the fossa ovalis as well, and it comes down around via the crista terminalis, and it crosses this part over here, which I want to highlight here, which is really important. And this is a small section between the tricuspid valve and the inferior vena cava's opening, and this region is called the cavo-tricuspid isthmus. So typical atrial flutter is also known as cavo-tricuspid isthmus-dependent atrial flutter, since it depends on the electricity propagating through this region of the right atrium. So atypical is non-cavo-tricuspid isthmus-dependent, and it usually happens as a result of previous surgeries on the heart or cardiac disease or congestive cardiac failure as well. Since a counterclockwise flutter is much more common, we're going to be discussing that first. So on an ECG, you are supposed to see flutter waves in this type of rhythm. You can have negative flutter waves in the inferior leads. If we draw a triangular diagram of the heart in which the right atrium is more anterior as compared to the left atrium, we will see how the electricity goes up and goes into the left atrium through the right atrium. So we understand that the current is going away from the inferior leads majority of the time, and that is why you get inferior leads negative flutter waves. So here is an example of the negative flutter waves that you will see in a counterclockwise atrial flutter. These are your negative flutter waves, and these give the ECG the shape of a sawtooth appearance as well. Now, it's very important to realize that the left atrium is more or less passively activated by the flutter that is going on in the right atrium. And we'll take a look at how the left atrium is activated as well. So you've got the right atrium and the left atrium. You've got the anterior chest wall over here. You've got a Bachmann bundle anteriorly, which connects the right atrium and the left atrium. And you've got the coronary sinus posteriorly, which connects the two as well. So current is propagated via the coronary sinus from the right atrium to the left atrium. And then as a second step, it circles around the right atrium, goes up, and it's transmitted via the Bachmann bundle towards the left atrium as well. And that is how the left atrium is passively activated. And if we take a look at it closely, majority of the left atrium is depolarized in a more or less retrograde fashion. Now if we take a look at how the currents are in a clockwise atrial flutter, we're going to try to make a similar triangular diagram of the heart. So this time the current is coming down the fossa ovalis and it's going up the lateral wall of the right atrium. So you're going to get positive deflection in the inferior leads because the current more or less is going towards the inferior leads. And you're going to get a negative deflection in lead V1 in that current is going away from the unipolar lead. Let's look at the example of the right atrium and the left atrium. So you've got the Bachmann bundle anteriorly and the coronary sinus posteriorly. When the current comes down, it is transmitted via the Bachmann bundle to the left atrium. And then via the coronary sinus afterwards. This is part of the reason why a majority of the current is going towards the inferior leads, and you can see positive deflection in leads 2, 3 AVF. Atrial rates are usually quite high. They're in the range of 240 to 330 beats per minute. And that is manifested with a very chaotic yet regular baseline when we take a look at the ECG strip of a atrial flutter. So if we take an example over here, you've got flutter waves between the RR intervals. And this gives the ECG the appearance of the sawtooth, which we spoke about earlier as well. So if we look at the electrical system of the heart, you've got the SA node, the intranodal pathways going down towards the AV node. And you've got the bundle of His and the right and left bundle branch. The AV node has an intrinsic property of being able to conduct only 150 plus minus 20 beats per minute. When it's bombarded with around 240 to 330 beats per minute, it's not really able to conduct all of those impulses, and a physiologic block develops. The most common physiologic block is 1 beat is conducted for every 2 beats that are coming from the atria, so it's a 2-to-1 block. In this ECG we've drawn over here, we've got 3 flutter waves with 1 QRS complex, so that is basically a 3-to-1 block. Patients who are on beta blockers and calcium channel blockers will have a higher degree of AV block. So they can have either a 4-to-1 block or a 5-to-1 block, and sometimes they can even have varying degrees of block in the same rhythm strip. In very rare circumstances, you can have atrial flutter with 1-to-1 conduction, and this happens in high catecholamine states, or patients who are on very specific antiarrhythmic drugs. An example of that would be flecainide, or if the patient has a bypass tract, an example of that would be Wolff-Parkinson-White syndrome. A personal favorite of mine is a big rule, which was coined by a Viennese cardiologist, that states that if a P wave is directly between 2 QRS complexes, there is a high probability that there is a P wave buried inside or hidden inside the QRS complex, and it increases your probability of diagnosing a atrial flutter. So we're going to circle back towards the concept of cycle length again. And like I said, electricity has a certain velocity as to how quickly it circles around the right atrium, and that cannot be faster or slower and has a precise time, which is why you can have a cycle length of more than 180 milliseconds in atrial flutter, because it is a very fixed pathway it takes around the atrium, as opposed to what it does in atrial fibrillation, where the electrical activity is very haphazard and you can have smaller cycle lengths because it is not wrapping around the entire right atrium and it takes a lesser time in going from point A to point B. So the cycle length can be less than 160 milliseconds. Practically, it can be done on an ECG strip when we take a look at the distance between two flutter waves or two fib waves. So if this distance shown over here is anything more than 4 small boxes, it is more likely to be a flutter as opposed to a fibrillation. If the distance is quite small, then we know that the cycle length is quite small as well. We're going to be doing a couple of practice ECGs now. So if you take a look at this rhythm, it has a narrow complex rhythm. It's being aberrantly conducted in that it has a right bundle branch block appearance, but we can see that there is some degree of atrial activity going on, and it's quite a regular tachycardia as well. So that was atrial flutter with a 2-to-1 block. Again, we've got another ECG that is a narrow complex tachycardia. The QRS duration is less than 120 milliseconds. You can see very clear flutter waves in V1 as well, and in the inferior leads as well. So this is a atrial flutter with a 2-to-1 block again. So these are the inferior leads flutter waves. Another example over here is that of a narrow complex regular tachycardia. You can see very clear flutter waves in V1 as well, because that is the closest to the atria. You can see that there are inferior lead flutter waves, which are very easily appreciable, and they give the characteristic sawtooth appearance to the ECG as well. Let's take a look at another ECG. So you've got narrow complex tachycardia again. The RR interval is not changing throughout the ECG. A P wave or a flutter wave is directly interposed between the QRS complexes, which makes it more likely that it's an atrial flutter. This was an ECG which was from a patient having an atrial flutter. They were given adenosine at this point, which completely blocked the ventricular beats, and you can see the typical flutter waves at the baseline. That's all for today. Let me know in the comments section if this was helpful or not. Don't forget to like, share, and subscribe to the channel, and have a good day.